This was a 22-year-old male patient who had a failed Nuss procedure, and I recently performed another surgery on him. This patient was discovered to have pectus ectopitum since childhood, and the deformity worsened after puberty. He was dissatisfied with the appearance of the chest wall, so he always hoped to get treatment. 3 years ago, he underwent Nuss procedure in a very famous hospital, but it had no effect. The patient recently admitted to my hospital for surgery in order to completely correct the deformity. The physical examination upon admission revealed that scars were visible below and on both sides of the patient's anterior chest wall, with an area of depression in the anterior chest wall and the obvious protrusion of the rib arch. Imaging examination showed a severe depression in the anterior chest wall, a stubborn shadow in the chest cavity, and a severe compression of the heart. The patient's diagnosis was clear. That was a severe compound deformity after failed Nuss procedure. His surgery was done under general anesthesia. Incision of the scar was made first. The stubor was exposed and taken out. The structure of the chest wall on both sides were exposed through the incision on both sides of the chest wall. During the operation, it was found that the anatomical layers of the lateral chest wall was chaotic, callus formed, and severe adhesion existed in the thoracic cavity and retrosternally. One procedure was performed at first to completely eliminate the depression, and then a William procedure was used to correct the protrusion of the rib arch. The operation went smoothly, took 2 hours to complete, and was completely success. After surgery, the chest wall deformity completely disappeared, and the appearance of the chest wall returned to normal. This operation is very challenging chest wall deformity corrected surgery. Due to the large area, deep decay of the deformity, and hard bone, the operation was extremely difficult. Since it was second operation, there was a severe adhesion in the chest and behind the sternum, which not only increased the difficulty of the operation, but also brought huge risks. We used a special technique during the operation which not only successfully eliminated surgical risks, but also achieved very satisfactory results. Analysis of the reasons of the failure of the first operation should be directly related to the number, shape, fixation position, and the fixing measures of the stubors. If the doctor does not have a professional understanding of the valve issues, the operation will fail. I'm Dr. Wang from China.